Hello, I'm Eileen Sullivan, longtime Waldenstrom's patient and volunteer support group leader in Eastern Massachusetts, here in Boston, Massachusetts. I'd like to take a minute to introduce this recording of our recent support group meeting focused specifically on Bing-Neel syndrome. This is the first attempt by the IWMF to reach a particular group of patients and folks who are particularly interested in this rare syndrome within our already small group of patients with a rare cancer. I'd like to thank Michelle Postic from the IWMF office, Chris Patterson from the Bing Center, as well as several members of our local support group here in Boston who are Bing-Neel patients for all of their help in planning this meeting. Participants joined from 11 different countries and countless American states. And as a result of this meeting, plans are underway for follow-up opportunities. The first portion of the meeting consisted of small breakout rooms where patients, caregivers, and interested others could meet one another and share. We then moved into presentations from two of our Waldenström specialists from the Bing Center here at Dana Farber Cancer Institute. At this time, I'd like to introduce our first presenter, Dr. Stephen Treon from the Bing Center for Waldenströms at Dana Farber. Thank you, Steve.
Thank you, Eileen. It's really a great pleasure for me to be here with you. And I want to thank you and Michelle as well for making this opportunity possible for us to actually talk about Bing-Neel syndrome. As you rightfully said, this is an unusual presentation for patients with Waldenstrom's macroglobulinemia, but there are a lot of patients now living with Bing-Neel syndrome. So I think this is really an opportunity to be able to talk a little bit about the disease pathogenesis and treatment. And of course, my colleague Jorge Castillo will expand on treatment later during this presentation. The title of my talk is Diagnostic Workup and Presentation of Waldenstrom's Macroglobulinemia Related Bing-Neel Syndrome. Now, I think it is really important that the presentation today on Bing-Neel and Waldenstrom's are for educational purposes only and should not be construed in any way to represent individual advice for patients. This is because the care of patients is far more complicated than one might just surmise from the presentation today. So please refer to your care providers for all advice on management and care. And due to the Health Insurance Portability Act, which is more familiar to all of us as HIPAA, the faculty will be unable to discuss individual patient cases during this presentation. And both Jorge and I thank you for your kind understanding. Now, Bing-Neel syndrome was first described by Jens Bing and Axel Neel, this back in 1936 when they submitted their paper to Actica Scandinavica. And you see the pictures of these two physicians, Jens Bing as well as Axel Neel here on the right side. What they had described were neurological deficits associated with hyperglobulinemia and the presence of lymphocytes and plasma cells in the central nervous system. Their description actually predated that of Jan Waldenström, which occurred in the same journal of Acta Scandinavica, but in 1944. So many years later that there was actually the description of Jan Waldenström. So their understanding of this constellation of symptoms predated by about 8 years' time. Now, when one talks about Bing-Neel syndrome, it's important to first understand that when you go back and look at the literature, people called Bing-Neel syndrome all kinds of things. But what we're talking about is the infiltration of malignant lymphoplasmacytic cells or Waldenström cells in the central nervous system. And the way this can happen is that the cells can actually infiltrate the meninges. This is actually the lining of the brain itself. And this is very, very common. This is probably by far the most common site for Bing-Neel syndrome to actually manifest itself. But you can also have discrete tumors within the brain. This is, of course, less common. You can find the Waldenström cells circulating in the cerebral spinal fluid. This is the fluid that actually cushions our brain against the skull, but also transverses all the way down to the spinal cord, where it also helps protect the spinal cord itself. And as a result, one can see also infiltration of the spinal cord very often by Waldenström cells in Bing-Neel syndrome. So this is also part of the Bing-Neel syndrome itself. You can also get infiltration of the eye, and this occurs by tracking of nerves from the central nervous system into the eye along the ophthalmic nerves. And this too would be considered Bing-Neel syndrome. Now, a very comprehensive paper that I think has provided us a lot of good data over the years in our understanding of Bing-Neel syndrome was published in Hematologica in 2015 by the French group led by Laurent Simon. And this, along with a number of neurologists, as well as the Waldenstrom's Dr. Véronique Leblond, who has made tremendous contributions to our understanding of Waldenstrom's macroglobulinemia. And in this paper, they analyzed 44 French patients who presented with Bing-Neel syndrome. Now, the presenting neurological complaints as part of the study are shown here. And I think, you know, the first take home is there isn't one particular symptom that would herald somebody to think that they have Bing-Neel syndrome, or for that matter, have a doctor diagnose Bing-Neel syndrome, because for every one of these symptoms, there's often many other conditions that can contribute. But I wanted you to see this because in aggregate, it shows you the diversity of symptoms with which somebody with Bing-Neel syndrome can present. The most common of which is balance disorder or disturbances in gait, occurring in about 48% of patients. There's ataxia, or lack of muscle control or coordination of voluntary movements. This can occur both in peripheral limbs, but also in the face, as well as the eyes, leading to palsies. And this occurs in about 36% of all patients. Difficulty in memory, cognitive impairment, trying to remember things, dementia, this can occur. And one of the best examples that I can give you is a pilot that I took care of, somebody who used to fly, very large aircraft. And when the Bing-Neel syndrome set on, this individual couldn't even remember how to turn a doorknob. So this shows you, how much impairment one can sometimes see with Bing-Neel syndrome. Sensory deficits also can occur along with headaches. There can be pain. This is a little bit less common, and the pain usually involves the back, the neck, as well as the limbs. There's also this entity called quadra equina syndrome. This is where the sacral part of the spine, the lowest part of the spine, where disease can manifest itself. And this is a very important area because you see a bunching of different nerves that end up innervating various structures in the pubic area, around the pelvis, and down to the legs. So when a tumor can infiltrate here, you can have loss of bladder control, loss of bowel control. You can also have difficulty with movement, as well as paresthesias, different senses below and around the perineum and in the legs. Deficits in function, meaning paralysis, selective paralysis of limbs, but also paralysis of half the body, what we call hemiparesis, where you get weakness on one side, convulsions, as well as aphasia. And aphasia is, of course, where you just can't speak. You can interact, but you just can't, produce speech. So again, a very, very diverse list of symptoms with which patients with Bing-Neel syndrome can present. The one thing you want to make sure of, though, if you have somebody with Waldenstrom's, is to make sure that it's not because of hyperviscosity, which is why we always check the IgM levels as we're working up these patients to make sure it's not because of the very high viscosity load in the blood. Now, there's a couple of highlights in the characteristics of these patients, which I think are worth emphasizing. And the one that I think is most impressive is that even though about 2/3 of the patients who were diagnosed with Bing-Neel syndrome had a prior history of Waldenstrom's, 1/3 of them actually presented with Bing-Neel syndrome as their first presentation of Waldenstrom's. Among the previously diagnosed patients, the average time or median time to the diagnosis of Bing-Neel syndrome was about 9 years. So it really showed that, this syndrome could come on to patients with Waldenstrom's, many of whom had been treated and were doing quite well. And then you have all of a sudden this relapse take place 9 years. And for many of these patients, which I think is very interesting, only a small handful actually had their Waldenström progressing anywhere else, only 29%. So most of these patients were doing quite well, had no evidence of their IgM going up or other signs of their disease growing systemically, but yet they relapsed in the brain. And that's why, we always have to keep, our antennas up when patients come, and even these subtle complaints they may have, neurological ones, we have to take very seriously. I think what's also important just to relay from this data is that once patients complained of neurological problems, it still on average took about 4 months before they were recognized to have Bing-Neel syndrome. So it does show you that there's still, a learning deficit that's out there, and the time to workup can often lag. Now, for most of the patients, when they were diagnosed with Bing-Neel syndrome, the disease was diffuse. It usually involved the leptomeninges. It was very seldom that they actually had a solid tumor within the brain, which was 9% in this particular case. Now, I do want to talk a little bit about imaging, because this was addressed in this paper. MRI abnormalities were seen in 78% of the patients. So there is still a small fraction where the MRI is not going to make the diagnosis of the disease. Conversely, CT scans were not very reliable, because only 36% of patients showed an abnormality in CT scans. So it's important to keep in mind that MRI becomes the study of choice, because it can pick up things in the brain, even subtle things in the meninges, but also abnormalities in the spinal cord. And in fact, 70% of the patients who had abnormalities in their brain also had abnormalities on their spinal cord, which is why we strongly advocate that MRIs be not only the tool for evaluating Bing-Neel syndrome, but that you should also do brain and spinal cord MRIs as part of that evaluation. Now, in addition to imaging, a lumbar puncture becomes very critical, because sometimes you can have abnormalities showing up by MRI, but you still need to make a tissue diagnosis, because there are a lot of things that can cause those abnormal images to form. Most typically, when we do a lumbar puncture, we're sampling a little bit of the cerebrospinal fluid. And in doing so, we look at the kind of cells that are present. We enumerate the lymphocytes. We look, under the microscope using Giemsa stain. It's a very specialized stain that allows us to look at blood cells to see what their form is. Do they look like lymphocytes? Do they look like plasma cells? But we also use staining that allows us to characterize those cells to see if they're lymphocytes, and if so, are they related? Are they part of the same clone? There's also a technique known as flow cytometry, which is a very specialized technique where you actually use antibodies to identify B cells, and then you actually, use additional antibodies to show if they're related to one another. And in this case, if you're looking at this slide, you'll see this big ball of cells over here showing up. And these cells were not only B cells, but they were related to one another, because one of the proteins that was being checked, in this case, the kappa light chain protein, these were all staining for that. So that's one of the ways that you can help identify if there are B cells related to the Waldenström, and if also they have the same light chain in the patients that, initially presented with Waldenstrom's macroglobulinemia. Now, Mutated has become a very important tool, not only for the diagnosis of Waldenstrom's, but also for the diagnosis of Bing-Neel syndrome. As many of you recall, because of support from the IWMF as well as by Dr. Peter Bing, we were able to do whole genome sequencing that identified the MYD88 mutation in about 93 to 97% of all Waldenstrom's patients. Now, this is actually a very interesting target, because thanks to the work of Lian Zhu in our group, she was able to make these very, very sensitive assays called PCR assays, allele-specific PCR assays. These assays can actually pick up the MYD88 mutation at a frequency of less than 0.5%. So if you have cells, even in the cerebrospinal fluid, as long as they're present at a at 0.5% or higher, they can be picked up by the PCR. And the way PCR works is you end up putting the DNA into a machine, and then it cycles, and the fewer numbers of cycles it takes to detect a mutation, the stronger it is. And you can see here all the Waldenström people lighting up. You see, though, in other diseases that make IgM, sometimes like IgM myeloma marginal zone, fewer or none of the patients had the mutation. In CLL, which is a closely related Waldenström disease, very few patients do have MYD88. And of course, people that have the IgM-MGUS, some of them can have it, and the stronger the signal, the more likely it is that they'll actually evolve to Waldenström. So this becomes a very easy tool to be able to use for doing a diagnostic workup. And thanks to the work of Dr. Stephanie Poulain and Dr. Xavier Lelou. Xavier actually was with us for many years in our laboratory, but then went back to France and ended up doing a lot of molecular work in Waldenström. But they were able to rapidly translate our MYD88 discovery into using it as a diagnostic tool for Bing-Neel syndrome. And I just want to share with you their work. I just first have to show you Xavier, who was one of our postdocs back here in 2006. And here is Lian Zhu. You see here Zach Hunter. You also see here Chris Patterson. He'll never age, but I just wanted to make sure you saw his picture here. But the thing to keep in mind is that thanks to the support of Peter Bing, we were able to bring together really an incredible group of international doctors and scientists that really helped us accelerate all these discoveries. So let me show you what Xavier Lelou as well as Stephanie Poulain showed us. Well, they had 3 patients in this series that they published. And you can see here, these patients presented with different kinds of symptoms. This young patient, 36 years old, came in with visual loss. He was having drop attacks, and that's how he presented. He had no symptoms of Waldenström anywhere else. The patient who was 59 years old, she had progressive leg palsies and blurry vision. And then patient number 3 was confused. They had cognitive decline. They were having trouble swallowing. They were having paralysis over part of the face, hearing loss, difficulty walking. So again, you see how diverse that these patients, present. And of course, they had workup which revealed that they had systemic Waldenströms, but that came after their diagnostic workup, which included looking at their cerebral spinal fluid. In this case, the MYD88 mutation was found in all 3 of these patients. And in one of the patients, the 36-year-old who had a leptomeningeal tumor, this patient also had the MYD88 detected by biopsy on the tumor. And so it does show you how MYD88 can help us make the diagnosis of Bing-Neel syndrome. Now, at the 8th International Workshop on Waldenström, and this shows you here the closing ceremonies of that meeting, which actually closing ceremonies took place in the UK Parliament. But one of the highlights of this meeting was that we had a task force on Bing-Neel syndrome that came together. And you can see the names of all the individuals. I had the privilege of co-chairing this task force with Monique Minima from the Netherlands. And Monique then went on and wrote up the task force guidelines, which I'm going to share with you in just a second. But you can see here what a distinguished group of international scientists, including our very own Jorge Castillo, was part of this effort. These guidelines were published in 2017 in Hematologica. You see there Dr. Monique Minima, who's based at the Netherlands. She then went on and chaired our international workshop number 9, which took part in the Netherlands, along with Maria Jose Kirsten and Steve Pauls. I think one of the largest and best meetings that we then had. But let me focus a little bit on what the task force, recommended. These were the consensus of all the experts. And of course, they recommended that anybody who's being suspected of having Bing-Neel syndrome should have an MRI of their brain as well as spine. I won't bore you with the particulars of the type of MRI that should be used, but in general, this is the kind of MRI that we do when we suspect a tumor or lymphoma to be present. One very important point, it's always important to do the imaging before you do the lumbar puncture, because sometimes when you do the lumbar puncture, it can actually mess things up and lead to non-specific enhancement around the meninges, and that complicates things. Then you don't know if it's tumor or if it's some sort of artifact. So that's why we always do imaging first, lumbar puncture second. Now, in addition, what is very, very important is actually tissue. You need tissue. Now, I know everyone is going to cringe on this call because what the task force recommended was brain biopsy if possible, okay? You're not gonna find a lot of people enthusiastic to run to do a brain biopsy. But sometimes if you have a solid mass, it may be approached through a biopsy and be definitive, which is why this is the recommendation that was made by the task force. More commonly, what we do, just alleviating risk, is to actually get cerebrospinal fluid through a lumbar puncture. And let me just go through here the list of things that we ideally like to see. One is we want to see the cell count. We want to see how many lymphocytes are present. If you have Bing-Neel syndrome, you should have an increase in lymphocytes. You want to look at the morphology of those cells and see if they look like lymphoplasmacytic cells or plasma cells that are typical of Waldenström. You want to look at the amount of protein because remember, Waldenström cells make IgM, which is a protein, and you can actually figure out on that cerebrospinal fluid through protein electrophoresis, just like we do on blood and urine, to figure out if there's a monoclonal protein present. The flow cytometry that I mentioned is important, but also the molecular testing, particularly the MYD88 mutation was recommended as part of the consensus workup of somebody suspected of having Waldenström's. Now, I already mentioned to you about MYD88, the L265P mutation, but I think what's very important to keep in mind is that it's really the aggregate of information that helps us make the diagnosis of Bing-Neel syndrome, because there are actually other lymphomas that can actually have MYD88. And very importantly, if you're working up somebody who has some suspected malignant event in their brain or spinal cord, is this entity called primary CNS lymphoma. And about 60 to 80% of patients who have this type of lymphoma also are MYD88 mutated. So that's why the MYD88 mutation in and of itself is not specific for BNS, but when detected, in the CSF or brain biopsy, along with all the other information that we've assembled, this becomes a tool. And one of the reasons why we remain excited about MYD88 is that we can also potentially use it as a molecular tool to see if our patients are responding to chemotherapy. We're always very concerned when we do a lumbar puncture if we get blood accidentally into the specimen because you can have circulating Waldenström cells that are MYD88 mutated contaminate the CSF. So the doctors always take an extra precaution of using the last tube that they draw to check for MYD88 because that lessens the chance that you might have accidentally punctured a blood vessel trying to get cerebrospinal fluid. Now, why is MYD88 important? Well, it's important because it's given us really a lot of guidance in the development of new therapies. My colleague, Dr. Yang, in our lab, made a very remarkable discovery because he showed us that after MYD88, is activated, it actually signals through Bruton's tyrosine kinase. But it also upregulates this other molecule called HCK, hematopoietic cell kinase, that's also very critical. It's what turns on BTK, it turns on other things that are important to the growth and survival of Waldenström cells. And of course, right off the bat, we got excited with this discovery because of all the BTK inhibitors that we had the potential to use. And in fact, 2 of the BTK inhibitors, Ibrutinib as well as Zanubrutinib, can actually also inactivate HCK. So you have really a twofer here where you're affecting 2 major components of the MYD88 pathway. And that's what Dr. Castillo is going to talk to you about momentarily, about how we're now using this knowledge to advance the therapy of Bing-Neel syndrome. But I think it is important for all of us in this call to recognize that, Waldenstrom's is a very unique disease because it's one of those diseases where the genome led us to understanding the signaling pathways, led us to identify new drugs, and most importantly, to do the clinical trials that actually led to the approval of new drugs for Waldenstrom's, including the first ever approval of a drug for Waldenstrom's, which was Ibrutinib. And the update of this study was just published in the Journal of Clinical Oncology. The original report was in the New England Journal of Medicine shown here. And I'm just very pleased to share with you all the exciting data in this study where these were all heavily pretreated patients. And just shy of half of them were refractory to their prior therapy. And yet 90% of the patients responded. And 5 years later, 54% continue to respond. And the overall survival is 87%. So that's very remarkable if you think about what a sick population entered into this study and participated in this study. Now, you've also heard about the CXCR4 mutation. This was discovered through the genius of Zach Hunter, who took all the whole genome data that we had and wrote his own algorithms and did all the computational science very differently and found this mutation. It affects about 30 to 40% of all Waldenström patients. How it fits in with Bing-Neel syndrome, we don't know, because so far, none of the studies that have been done really have been able to detect CXCR4. And that's because A, too few people have been tested, and B, really the work that goes into discovering CXCR4 mutations hasn't been done. So we don't really know the placement of CXCR4 workup in Bing-Neel syndrome, which is why we focus on MYD88. But I do want to leave you, with this very interesting image that was just published in the journal Blood. It shows us how all the advances that we've made in terms of understanding the underlying genomics of this disease, the underlying signaling of this disease is now leading to a whole plethora of new drugs. Not only Ibrutinib and Zanubrutinib, but other BTK inhibitors too, like acalabrutinib, tirabrutinib, but also these 3rd generation BTK inhibitors that bind to other sites on BTK. And I think what you can also get excited about is all the CXCR4 inhibitors that are also entering into the disease, and the drug venetoclax, which I'm hoping that Jorge is going to talk to you about more, which is also very, very pivotal in these signaling cascades. I'm sure in the next lecture that will follow, you'll be hearing more about how we go about managing patients with Bing-Neel syndrome. But I got to tell you, one of the absolute delights in my life has been able to partner and work with Jorge, who has really helped us innovate and advance the therapy of Bing-Neel syndrome. These are the messages that came as a summary of the task force on Bing-Neel syndrome. I think it's important to recognize that every Waldenström patient with atypical and unexplained neurological complaints needs to have a workup done. This includes radiological as well as lumbar puncture, just to be able to clarify if Bing-Neel syndrome might be part of the syndrome. And important, once again, radiology first, lumbar puncture second. I think it's very important to recognize that the diagnosis needs to be done on tissue. And that includes, the tissue workup of the individual who's suspected of having Waldenström's plus their CSF, and to use at our disposal flow cytometry as well as the molecular technology that we have. And one of the messages that I think will come out of Jorge's talk is the 3rd one, which is very, very important and recognized by the task force. And that is to go slow, not to really overtreat Bing-Neel syndrome, which by itself can sometimes have catastrophic significance, but to treat it with less intensive regimens. And I think what you're going to hear very shortly is how Ibrutinib and other BTK inhibitors, are very promising agents for the treatment of this disease. I just want to wish each and every one of you a happy Thanksgiving. And in giving thanks, I just want to say how proud we are of our patients who have contributed so much to our advancement and understanding of Bing-Neel syndrome, and how grateful I am for all my colleagues, those in the laboratory, my colleagues, Jorge Castillo, Shana Sorosiak, Catherine Flynn, Chris Patterson, who is really the glue that brings us all together. We're very blessed to have an incredible community, and we're blessed to have the IWMF supporting us. And thank you, Eileen, for making this day possible.
Oh, you're welcome, Steve. Thank you so much for helping us this afternoon. That was a lot to digest. And so if we can move on to Dr. Castillo, then we're going to get more, even more information. So I hope everybody is enjoying this. So.
All right. I mean, it's going to be, thanks, Eileen. It's going to be really hard to match Steve. I hate going after Steve, but anyway, I'll do my best to, you know, keep things at a level. I am going to start sharing my screen in a minute. And sorry about that. Just 1 second. Another time here. All right. Okay. Good. So, okay, so over the next 15 or 20 minutes or so, I'm going to try to talk about the management of this condition called Bing-Neel syndrome. As Steve said, has been a lot of some back and forth in terms of what Bing-Neel syndrome actually is and means and how can it be diagnosed. So I think the fact that we have now formal guidelines in terms of how to diagnose it and how to manage it, I think that has been a great advancement, I would say, on how to understand Bing-Neel syndrome so we can treat it better. So I'm going to start with this. As you all know very well, Waldenströms can present in many different ways. And some patients that come to our clinic actually are asymptomatic, and they found the disease. The disease was found, you know, trying to work out other reasons, other problems, completely unrelated sometimes to blood issues or things like that. Anemia remains the most common reason why patients do become symptomatic, fatigue, tiredness, low platelets, very rarely low white blood cell counts. And we talked about hyperviscosity previously with, you know, nosebleeds and headaches and blurred vision and some neurological deficits that we obviously have to have into account when we think about patients and potential Bing-Neel syndrome, cold agglutinin disease, cryoglobulins, neuropathy, amyloidosis. And as you can see there, we do have Bing-Neel syndrome. In our database, it's about 1% of patients that get to have this complication. And that makes things very difficult for physicians with a little less expertise, right? Because that's not what comes into mind when somebody thinks about, you know, a patient with neurological deficits. And in this situation, we always have to think about that as a potential possibility. So just to give an idea that how very specific that presentation could be and you know, in how patients can get affected. And if you don't think about that, then you're not going to diagnose it appropriately or manage it appropriately for that matter. Now, the data in terms of therapy is very limited. And it's limited in the sense that since the occurrence of Waldenström per se is a rare condition, and then Bing-Neel syndrome, a rare complication of a rare condition, really there are no prospective studies done in this situation. So there's not going to be any randomized data, any phase 2 data, and that limits a lot the things that we could potentially use. And we do have retrospective case series. You know, case series are situations in which large institutions have collected data along, you know, over the years, and they publish this data. And I think Steve mentioned a couple of these case series that are probably the largest. One of them is the French case series, about 44 patients that were published in 2015. And then the Dana Farber case series that included about 36 or 38 patients as well, published just the following year. And I just did a literature search, you know, last night just to be fully updated for this presentation today. And when you actually put Bing-Neel syndrome in a PubMed, which is a search engine for the medical literature since 1950 all the way to now, and it's at 70 years of medical data in one place, there are 104 articles on Bing-Neel syndrome. And that's all there is, 104 articles over the last 70 years on this condition. Now, in just a couple of case series, so the majority of the things that we tend to recommend for Bing-Neel syndrome are actually based on case reports. Case reports are anecdotes, situations in which a physician finds a diagnosis, he decides to treat based on specific reasoning, medical judgments. And if these approaches are successful or not, then they get reported. And many of these cases are just one case or two cases or even three cases treated with these conditions. And that actually is what makes the bulk of the evidence on how to treat patients with Bing-Neel syndrome. As you can understand, that is not a very strong data to suggest or recommend specific things to be done, but understanding how Waldenström works and how other lymphomas work and how myeloma works, then we can actually make some assumptions and transpolate some data from other conditions into Waldenström's and into Bing-Neel syndrome. So a lot of what I'm going to mention moving forward is going to be within this framework. I think a very important aspect of things to begin is just understanding that there is a physical blood-brain barrier. And what do I mean by that? So this is a blood vessel that has been basically cut in half, and this is in the brain. So as you can see here, the blood runs within this vessel. These are the cells that make up the vessel, and this is the brain cells around it, the neurons and the astrocytes and all these all fancy cells that are actually in the brain. Now, I want to bring your attention to these little spaces in between the cells that make up the blood, the actual vessel. And you can see that they're very tight. They're very tight, one on top of the other. So that acts actually as filters of very, very small molecules. Therefore, only very small molecules can actually go through these little vessels. When you actually looked at these cuts in a regular blood anywhere else in your body that is not the brain, these junctions, these fenestrations or windows, we call them, they're actually a little larger. So larger molecules can be exchanged between the blood and the rest of your system. But in the brain, these junctions are so tight that very, very few molecules can pass through. Just to give you an example, a large molecule that we use very often in Waldenström's is rituximab, for example. Rituximab is such a large molecule that it does not cross through these tight junctions. And that's why in many scenarios, sometimes rituximab doesn't successfully create a good penetration into the brain tissue, specifically because of the existence of this blood-brain barrier. And you will see how that plays a role in how we treat patients with Bing-Neel syndrome in a minute. These are the treatment options for Waldenstrom's macroglobulinemia. It's a list that keeps growing over the years, and that makes us all happy, you and us. So we have monoclonal antibodies, and we do have rituximab, ofatumumab. We have the chemotherapeutic agents that we use, fludarabine, bendamustine, cyclophosphamide, and the proteasome inhibitors that we borrow from myeloma, bortezomib, carfilzomib, ixazomib, and as Steve alluded earlier, BTK inhibitors like Ibrutinib, acalabrutinib, and Zanubrutinib. These are the medications that we use the most. There are other medications that we use as well, but I wanted just to bring your attention to these ones that are the ones that we use the most when we take care of patients with Waldenstrom's. Now, the question is, how many of these actually do cross the blood-brain barrier? So as you can see here, the treatment options for patients with Bing-Neel syndrome, the list actually decreases. Monoclonal antibodies are not, do not cross into that space. Proteasome inhibitors do not cross into that space. We are left with chemotherapy and with BTK inhibitors. And within the chemotherapy agents, we do have fludarabine and bendamustine that there's some data that they do work in this setting. Cyclophosphamide, very, very little data, and that's why it's kind of grayed out there. We think about BTK inhibitors, and then Ibrutinib, there's data on it, and I want to show that to you, Zanubrutinib as well. Really no data on acalabrutinib that I'm able to show, at least until yesterday. I couldn't find any report that acalabrutinib actually can be used in patients with, or has been used in a patient with Bing-Neel syndrome, and that's why I grayed that out as well. And you can see here that I added a couple of agents here that were not included in the list for patients with Waldenström's. And one of these agents is called methotrexate, and another agent called cytarabine. These are chemotherapeutic agents that are used for a more aggressive brain lymphoma called primary brain lymphoma. For that condition, it's a very aggressive disease, and we use these medications, methotrexate and cytarabine. So as you can understand, if this is Bing-Neel syndrome, is a lymphoma, lymphoplasmacytic lymphoma, Waldenström's that affects the brain, one of the first instincts was to treat patients with Bing-Neel syndrome with these chemotherapeutic agents, the ones that are in blue here, methotrexate and cytarabine. Now, the issue with those agents, I want to say that they do have some efficacy against Bing-Neel syndrome, but these medications tend to be on the toxic side. Methotrexate, for example, need to be admitted intravenously in the hospital. Patients need to be admitted to the hospital. They need to stay in the hospital until we make sure that methotrexate has been removed from the system. It takes, sometimes few to several days for that clearance to occur. And the toxicity associated with methotrexate goes from liver damage to kidney damage to mucosal damage, and obviously affection of involvement of our blood cells and things of that nature. Cytarabine is another agent that can be used in this setting, but again, we need to give it in high doses, very much like methotrexate, and that can also cause some brain toxicity as well, and some blood issues. So these are medications that we have used in the past, and I think we have more experience with. And they do have some efficacy, but they do have a lot of toxicity as well. And that's what I wanted to bring your attention to, these newer agents, these other chemotherapeutic agents that are, I would say, less toxic, but also with efficacy. And we'll talk about BTK inhibitors afterwards, that also has a high degree of efficacy with much less toxicity than what we have seen with the other chemotherapeutic agents. So this is one of the initial reports that I alluded earlier. This is our experience at the Dana Farber with Bing-Neel syndrome. And we can see here how, this was published about 4 years ago. We do have experience with high dose methotrexate. This is MTX is methotrexate. The DAC is actually cytarabine. So as you can see here, we have used these agents in the past, and they do have efficacy. We do have responses, anywhere between 60 and 80%, but we do have also responses with fludarabine. But again, you can see the numbers here. We're talking about single digits experience, and as well with bendamustine. At the time that we published this paper in 2016, we had very, very little experience with Ibrutinib in Bing-Neel syndrome, and that's why this agent has not been mentioned in this study, but I'm going to talk about that in a minute. Similarly, when we think about the report from the French Innovative Leukemia Organization, the PHILO, this is the 44 patients in the study. Again, cytarabine, fludarabine, even some transplant, radiation, right? You don't see Ibrutinib here in this, just because this report was from 2015, when Ibrutinib was just getting approved for Waldenström's, and obviously the experience in Bing-Neel syndrome specifically was much more limited. And again, we do have some efficacy here with response rates up to 70%, similarly to what we saw in our own report as well. So we can see that we have effective therapies, but the therapies need to be highly selected for agents that can actually cross that anatomical blood-brain barrier. Now, the newer chemotherapeutic agents, I don't want to say they are newer, much newer than methotrexate or cytarabine, but in the sense of using it in Bing-Neel syndrome with efficacy. The Dutch group, reported these initial 4 patients that received fludarabine. Now, in the Netherlands, at that time, fludarabine could be given as pills. In the United States, we do not have, the pill form of fludarabine. We do it intravenously, but has become one of the agents, chemotherapeutic agents, that we use more often in patients with Bing-Neel syndrome, specifically because it penetrates into the crosses the blood-brain barrier very effectively, and we can induce responses in patients with Bing-Neel syndrome. The other report came from Italy, in which a patient, just one patient treated with bendamustine and rituximab, and in 2015 with Bing-Neel syndrome, had some efficacy in there as well. So based on this, when we compare the toxicity rates that we see with fludarabine and bendamustine, it seems to be more favorable, at least from our perspective, compared to methotrexate and cytarabine. And for that reason, going a little less intensive, as Steve was mentioning earlier, is the way to go in these type of patients. Now, in the guidelines that were put together in 2017, we can see here how after a diagnosis of Bing-Neel syndrome is made, we need to decide if the patient is symptomatic or asymptomatic. Now, I want to bring your attention to this asymptomatic scenario because we haven't talked about that much. But I have had a case, for example, in which a patient had a severe headaches, the patient had a lumbar puncture, MRIs, and then malignant cells with Waldenström were discovered in the spinal fluid. When the patient came to see me, the headaches had resolved with no specific therapy. And at that time, the patient is essentially asymptomatic. Didn't have any issues with weakness, neuropathy, sensation problems, or anything like that. So we decided to observe a patient. So we do have a handful of patients who were formally diagnosed with Bing-Neel syndrome, but they are otherwise asymptomatic. And in those scenarios, we do observe without interventions. Obviously, we do have a low threshold, and we observe those patients very closely to make sure that they do not become symptomatic acutely. Now, if the patient does become symptomatic, we provide a list of here of the purine analogs, that is fludarabine specifically, bendamustine, or Ibrutinib. And as you can see here, high-dose methotrexate and high-dose cytarabine are also listed as they should be, but a little bit lower in the whole scenario. Now, there is an approach here called intrathecal therapy. Intrathecal is essentially this methotrexate or cytarabine that is actually injected in the spinal fluid of patients. And that is something that we have used in the past very often for other lymphomas. And we have used that up to some degree in patients with Bing-Neel syndrome as well. However, with the newer treatments, as they do penetrate very nicely into other tissues, we have been using these intrathecal injections less and less. Now, if a patient is not a candidate for any of these treatments, maybe in that situation, injections of chemotherapy directly into the spinal space might be a way to go, but it is not something that we use very frequently nowadays. Now we get into BTK inhibitors. And I think this study was a very important study. This is a study that was published 3 years ago. This actually was in conjunction with us. This is a patient that was seen by us and shared by another physician. And we were able to obtain actually spinal fluid from this patient and measure Ibrutinib levels on this patient. And this is a patient with formerly diagnosed Bing-Neel syndrome. You can see here how there's a bright spot on the frontal area here that after initiation of treatment actually resolves. There's no more brightness in there, and there's no more enhancement on this side. So in this study, we actually were able to prove that Ibrutinib at a dose of 420 milligrams and a dose of 560 milligrams actually provided a good penetration of the blood-brain barrier and good levels of therapeutic levels actually of Ibrutinib in the spinal fluid. Now, there were higher levels in the spinal fluid when we used a dose of 560 milligrams, and there were lower levels when we used a dose of 420 milligrams. And there's still some debate in terms of what is the best dosing for patients with Bing-Neel syndrome, 420 or 560. There are some good and bad things about both approaches, and we'll talk about that in a second. And for that reason, we put together our own experience with Ibrutinib, and we actually talked to other colleagues from Australia, in the United States, as well as Europe. And we put together this study that got published last year. This is probably the third case series in this disease. 28 patients with Bing-Neel syndrome treated with Ibrutinib. And in this study, we could see that the patient symptoms actually improved in about 80% of patients within 3 months of therapy. And actually the MRIs actually improved also in about 60% of patients within 3 months of therapy. Interestingly enough, what we have seen is that only half of the patients actually, the spinal fluid actually cleared. So that's an important message, right? Because when we think about Waldenström's, we think about an incurable condition. We think about a condition that we can treat and we can control, but sometimes achieving that clearance of the disease, that complete response, is not something that we actually aim for. And therefore, our philosophy on Bing-Neel syndrome has also evolved over years. You know, do we need to be aggressive enough to clear the spinal fluid if we can actually make the patient's MRIs look better, make the patients feel better, even though there are some floating, you know, Waldenström cells in there that are basically just more like bystanders and not really causing the patient any type of symptom? Do we need to be more intensive just to, you know, attain that clearance of spinal fluid, but at the cost of more toxicity? So our approach at this time is maybe we do not need to achieve that clearance of the spinal fluid as long as the patients do well. And I think that's an important aspect of things, because in this study, in some patients were up to 4 years, you can see each of these little marks on the curve of survival is a patient. We have patients all the way up to 4 years. And, you know, 3/4 of patients were, you know, doing very well 4 years out into therapy with Ibrutinib. You know, so this is a treatment that has come to in our practice much more importance over the last years. So Steve and I recently published a paper on the management of Bing-Neel syndrome, and we followed the recommendations by the international groups. But in this, we went a little bit beyond in terms of saying that our preferred approach is the use of Ibrutinib in patients with symptomatic Bing-Neel syndrome, as long as it's affordable and as long as it can be done, and as long as it has not been used in the past. Because Bing-Neel syndrome can occur at any time during therapy. Patients can be on treatments and then develop Bing-Neel syndrome. They can be on treatment with bendamustine. We have seen it on treatment with Ibrutinib and they develop Bing-Neel syndrome. So if somebody develops Bing-Neel syndrome after being exposed to Ibrutinib, then obviously Ibrutinib is not the answer there. But if a patient has not been exposed to Ibrutinib before and developed Bing-Neel syndrome, then Ibrutinib is definitely a good option to consider at that time. Radiation is not something that we use very often, but if a patient has disease just in one specific spot in the spine most commonly, then we tend to use radiation in that setting. If we think that, you know, systemic disease might not be the best approach at that moment. Now, the newer BTK inhibitors, Zanubrutinib, for example, has already one report. This is one case that has been reported in 2018. This is a case from Australia. You can see here some abnormalities in the spinal cord at different levels. And on treatment with Zanubrutinib at a dose of 160 milligrams twice a day, we do see improvements over time. So I think there is going to be maybe some mounting evidence as time goes by on the use of Zanubrutinib in Bing-Neel syndrome. But again, our experience is much more limited in that context, since Zanubrutinib has not been formally yet included as part of the national guidelines and has not been formally yet approved by the FDA for patients with Waldenström's, but hopefully an addition that will be made later this year or very early next year. Now, new agents, there are a couple of agents that I'm excited about, and one of them is venetoclax. Now, there is no data on the use of venetoclax in Bing-Neel syndrome, but there is this report on a patient with CLL, with chronic lymphocytic leukemia, and we know that venetoclax is very effective in that context. Venetoclax is approved by the FDA for CLL. It is not approved yet for Waldenström's. Hopefully next year we'll take care of that as well. But in this specific patient, venetoclax was able to clear the spinal fluid on a patient with CLL who had central nervous system. This is not called Bing-Neel syndrome because it's not Waldenström's. But the patient developed this complication on Ibrutinib, and venetoclax was able to rescue that patient. The other agent is Marizomib. Marizomib is actually a member of the proteasome inhibitor family. Bortezomib, carfilzomib, ixazomib, they form part of that, but none of those three actually are able to cross the blood-brain barrier. Marizomib, on the other hand, has shown to be effective in that context. This is a specific study from a patient from Dr. Badros at the University of Maryland. This was published a few years ago, and there's actually the planning of doing Marizomib in multiple myeloma patients with central nervous system involvement. It's going to be very specific in that specific situation. So I think that will be very, very important. And I think will be potentially another treatment option, even when it gets approved and even when it's available commercially, because it's not yet available commercially in the United States. That could be a couple of medications that we could potentially use. So the future is looking more promising, I would say, for patients with Bing-Neel syndrome with the advent of this newer treatment with novel mechanism of action. Obviously, none of this could be possible without the help of the team. The Bing Center for Waldenstrom's clinic has grown over the years, and it has been, I think, a pleasure for Steve and I to see that team growing over time. Now we have Shayna Saroshek added to our roster of physicians, and she's going to be focusing on Waldenstrom's. Catherine Flynn has been a fantastic addition. She's just so nice and so thorough, so complete. Kirsten, she's our senior project manager. She just tells us what to do, and we do it, and we know we're going to be just fine. And then we have Carly and Tim, our two clinical research coordinators. But again, none of the effort of this team would be of any value without the participation of our patients. We cannot advance the science just by wanting to advance in the science. I think the patients that come to see us, the patients that participate in our clinical trials, and the patients that provide their clinical samples really are the ones that help us advance the science. And we will not be able to do what we do without your help. And with that, I really want to thank you for your attention.
Thank you so much, Dr. Castillo. That was really very, very well done. And I think it's so helpful to think about these new things that are coming along. When somebody has a complication of a complication, such as Bing-Neel syndrome, to be able to think forward and know that there's perhaps light at the end of the tunnel is very helpful. Thank you so much. In terms of the question and answer portion, it's possible that there was something I should have set up in the meeting format online before the meeting started of using this raise hands feature. So I think what we will do is, I've already gotten one question in the chat, and I will call on that person to ask the question. So Ron, get ready. I'm going to call on you in a minute. And while we answer that question, if other people have questions, if you could just go ahead and chat to me. So you open up the little chat button at the bottom, and I think I'm the only one you're allowed to chat with. Although, so if you just chat to me, I'll call on you, and then you can ask your question, and we'll see how that works. Okie doke. So, so Ron, you're going to want to unmute yourself, Ron Holton from Texas, because this was a very good question. So go ahead whenever you're ready.
Well, my main question was what is the incidence of Bing-Neel? And that's been answered, 1% of Waldenström patients. The other question I had, Dr. Treon, you said something about 200 cases having been found. Maybe you meant having been addressed in a specific study, but it seems apparent that there have been a lot more than 200 cases over the years.
No, what I said, Ron, is that less than 200 cases have been reported in the literature.
Okay, thank you.
All righty, and so let's see, Andrea Schernman.
I think I know the answer, but I would just like to know the definition of the drop attack that was mentioned, because I think maybe I had one.
Yeah, it's a pretty generic term, but fainting spells.
Okay. Yep.
Yeah.
Yep. Okay. Thanks.
Is that what happened?
That happened.
Yeah.
Yep.
Now, some questions that are coming in seem to be very personal, and as Dr. Treon mentioned earlier, they can't give specific medical advice about your particular situation. So let's try to keep the questions focused on things that would be more generic, if that's okay. All right, here is M. Waitsman from the UK has a question.
Hello, and thank you for these brilliant presentations. I'm just wondering if over the last few months, anyone has noticed whether there's any evidence of an exacerbation of Bing-Neel connected with COVID-19.
I'm happy to take that question. The answer is no. We have not seen that specific occurrence. I think we have been relatively fortunate that our patients, I mean, I think it maybe just how our patients are. They are very careful to begin with, and they understand, you know, that they have an immune problem, and for that reason they might be in, you know, more into isolation a bit more than the average individual. So, but yeah, we have not really seen that complication.
Thank you.
Great. And, you know, I'm going to go back to Michael Knowlton, whose question was a little specific, but I think you could make it more general, Michael. So why don't you go ahead with that?
Thanks so much. My question really has to do with the ongoing assessment. Having been diagnosed with a leptomeningeal disease and now asymptomatic, at what stage would a patient be retested from a CSF perspective relative to being asymptomatic, or simply wait for something else to occur?
Jorge, do you want to?
Yeah, so our monitoring testing has actually evolved over time as well. When I took the clinic in 2013, 7 years, wow. So when I started seeing patients in 2013, our testing, I think it was much more invasive and much more intensive than what it is right now. I think we were, at that time, we were doing blood work, and we were doing MRIs and even spinal taps every 3 to 6 months. So over the years, understanding that, you know, the symptomatic improvement is seen, that the radiological improvement is seen, but only 40 to 50% of patients actually clear the spinal fluid, and doesn't seem to be, to us at least, that the presence of those, you know, cells in the spinal fluid has any clinical implication. We're actually spacing out the visits to every 3 months, which I think that's reasonable. But I think the MRI testing is actually being moved out to maybe just twice a year for about a year or so until we see some stability. And then, you know, sometimes once a year, and sometimes, you know, just as clinically indicated. Now, the spinal taps has really become something that we are not repeating for monitoring purpose, because let's say a patient feels well, let's say the IgM has decreased and the blood counts are normal, and the patient feels fine, and the patients are, let's say, on Ibrutinib on therapy, the MRIs are better. What am I gonna do if let's say I do a spinal tap and then it shows that you have, you know, 10 cells in the spinal fluid, or 100 cells, or 1,000 cells? You know, that's really not gonna change, you know, my approach in terms of what I'm gonna do. So we typically, at least in medicine, we try not to do tests that we will not use to make an actual decision. So in that setting, we have actually stopped monitoring patients with serial spinal taps.
Michael, it's
very helpful. Thank you.
It's a good question, but you know, the philosophy of Bing-Neel syndrome and its management really did change, because, you know, we were faced with an era where patients were being overtreated, where, you know, folks felt the goal was to eradicate disease completely in the brain. And that's really not, you know, possible for most patients. And as a result, patients got overtreated. And, you know, it was beyond the point where they became symptom-free from the Bing-Neel syndrome. And so all we ended up doing was inducing lots and lots of toxicity, which is really, you know, recognizing the notion here that there's going to be persistent disease, but we want to treat people to the point that we've alleviated brought on the therapy. And that's important for us to convey to our colleagues, because, you know, still a lot of our colleagues treat thinking that the goal is complete response. Jorge and I published a very nice paper. It's very seldom that you ever see a complete response in Waldenstrom's, but it doesn't mean that the patient isn't going to be feeling better and you're going to get them back on the path of wellness. The danger really lies in overtreating them and then, you know, causing another malignancy to come along, or giving them neuropathy, or suppressing their immune system, so that, you know, they then have, you know, recurring sinus and bronchial and other infections. I just want to remind everybody of something that Jan Waldenström used to say, and it's been ingrained in me, you know, let well do. You know, if the patient is doing well, you know, don't ruin it. And so that's really a very important caveat, you know, to treating patients with this disease.
Thank you so much.
All right, and so Kathy and David Warren, you have a question about, want to go ahead?
Yeah, well, I know it's that your assessment of treatment is how the patient is doing. And I know that you've told us that. I thought I heard, and I may have misheard this in one of the presentations, that you talked about the using of the MYD88 mutation as guidance on seeing if the medication is working. Did I mishear that, or is that something you do as well?
No, you didn't mishear, Kathy. I said that the ability to use MYD88 as a tool to monitor disease may also be realized. And by that, what I meant was in further studies. If and when Dr. Castillo and Dr. Sorosiak get us that cure, get us the drugs that are going to get us to a cure, then it makes sense to start using, this kind of approach. Now, even before we get to a cure, the ability to use MYD88 in lieu of IgM, if we start getting more and more patients into a complete remission, has value. Because we know in a lot of other diseases that, once you've gone beyond the pathologist being able to see disease openly in the bone marrow, there is value to getting patients into very deep microscopic, disease levels. And that's something, unfortunately, we really aren't there yet and able to do in Waldenström. We have the perfect marker. Everyone is envious of the fact that we have the MYD88 marker. It's the perfect marker for tracking disease. It's just that we haven't been able to get there. And, recognize once again, there is two, schools of thought. You either push hard on therapy at the cost of toxicity, and I'm talking about, short-term and long-term secondary cancers, immune suppression, neuropathy, a lot of things, right? Or you try to use drugs like Ibrutinib and Zanubrutinib to control the disease, suppress the disease, and do what we do for a lot of our diseases, high blood pressure, diabetes, cholesterol. We don't cure those diseases, we suppress them for long periods of time. But the cost of doing that is that it's tolerable. You're not hurting the patient in the in the attempt to help them. And so when we get to better drugs, and there's there's a lot of innovation in the making right now, then we can start looking to see if the MYD88 mutation can help us identify the patients who are doing better, and we're getting them to a place that we might even be able to stop some of these therapies, like Ibrutinib. Maybe if you get somebody down to very microscopic levels and you can show that by these molecular techniques, you might stop. But we still haven't proved that. We have the tools. We just have to prove that that is or is not the case.
So you're saying that the mutation, it could potentially it wouldn't go away, but it would not have the harmful effect? Is that what?
No. Look at the mutation as a marker. It's evidence of Waldenström. And you can count the number of molecules, mutated MYD88 molecules that exist. You can count it as it exists in the brain. You can count it as it exists in the bone marrow, in the blood. Just like you count IgM, you can use MYD88, to count it. It's just, as I said, we have the tools to count it. We just don't have the drugs to make it worthwhile counting.
Thank you. I didn't know. At least to
that microscopic level, yeah.
I didn't know you could count MYD88. I thought it was just, yeah.
A lot of things we can do.
That's great. So I'm going to see if we can move on to another question. And that is from Ron Gittleson from New York. Ron, do you want to go ahead?
Thank you. Yeah, this goes back to a discussion that Dr. Castillo and I had a couple of years ago regarding whether my condition would be considered Bing-Neel, just based on the presence of the Waldenström cells in my cerebrospinal fluid. And Dr. Castillo said that, well, we never took 100 Waldenström's patients and tested how many of them have the Waldenström cells in their cerebrospinal fluid. And so the presence of the Waldenströms in the cerebrospinal fluid doesn't necessarily mean that you have Bing-Neel. And I was wondering if there's any further data on that. If anyone's actually ever done a test of just random Waldenström's patients to see if maybe a lot of the Waldenström's patients have the cells in the cerebrospinal fluid.
Yes, hi Ron. Yeah, I recall the conversation, and unfortunately, it's a very difficult study to do, right? I mean, we need to number one, convince a lot of asymptomatic patients to have spinal taps, that they have their own risks, right? In terms of infection and bleeding and other problems, headaches. There's so many other issues with spinal taps in that context. And not only the patients need to agree, we need, the institutional review board, there's a group of people that review all the research that we do in patients. They need to agree that, for us to put needles in the spine of people who are otherwise feeling well, needs to have a good reason behind it, not just to satisfy our curiosity to tell you, oh yeah, some people do have it, some people don't have it, we're not going to do anything about that. So I don't think that it's going to be a very easy study to be done. I don't think that study will ever be done. So yeah, I don't think I can answer that question. I don't think we know, the answer to that question at this time.
Well, thanks for trying. It's always good to have things we need to work on. So I have another question from Peter Fries all the way over in Australia. Peter, are you ready?
Hi, thank you for that.
Oh,
I had a couple of questions. I'm puzzled about how Bing-Neel actually initiates. I carried the idea that it was hyperviscosity and that some kind of osmotic miracle took place and the cells moved from, intracellular across the blood-brain barrier. But given what's been said today, you can have very, very well-managed Waldenströms and still get Bing-Neel syndrome. So how does it initiate? I still have questions around what is the current life expectancy of someone with Bing-Neel. And it appears to me that there are more people being diagnosed with Bing-Neel now than ever before, or the family seems to be growing. So do we have more, or are we just diagnostically a lot smarter? Thank you.
Yeah, Peter, it's a great question. I think what it's important to recognize is that people with Waldenström are living longer and longer and longer. When I first got involved in this disease, the survival was 3 to 5 years. And a lot of the deaths that occurred because of the drugs that we're using. It wasn't the disease itself in many cases, it was really the chemotherapy that was inflicting, a lot of the deaths. And as we evolve to, newer drugs, including the nucleoside analogs, fludarabine, cladribine, you probably heard of those drugs too. Those drugs, cause secondary malignancies as well. And then we had deaths because of that. So I think as time has gone on, two things have contributed to the increased survival of Waldenström patients. One is that we've done away with drugs that had themselves a lot of toxicity, both short-term and long-term. But the other is very obvious, that we've also created newer and safer drugs that are keeping people alive. And when you look at the statistics that have come out of our center, the projected overall survival now may be greater than 18 years on average. And if you take somebody who's diagnosed at the age of 62, which tends to be close to our average, then for many, I'm not saying all, but for many of the patients, a normal lifespan can be assumed. Now, there are some differences. The patients that don't harbor the MYD88 mutation appear to be at higher risk of transforming to an aggressive lymphoma, and their survival is shorter. So some of the genomics can help us understand some of the differences. The point that I'm trying to make is as people live longer, this just gives the opportunity for some of these relapses to occur that you might not otherwise have recognized because the patients, would have lived a shorter period of time. When I ran the clinic, pre-Jorge, I used to see maybe 2 or 3 of these a year, or maybe hear of 2 or 3 more, a year. And, it was always crunch time as to what we did for therapy. Now there are months that we have, 5 cases a month that we see of new cases of Bing-Neel syndrome in our clinic. And look at the difference. In the prior years, we used to have to admit people to the hospital, give them high dose chemotherapy. It was very toxic. We had to monitor their levels and then bring them back 2 weeks later and do it again and again and again. And even with all that therapy, our success rate was about 40%. And now, you just give them Ibrutinib and you send them home. And, the chances of being successful are, at least 2 times more than what, they used to be. I don't even think it's even worth getting into the survival of Bing-Neel patients because quite honestly, Ibrutinib now has, changed completely the spectrum of how we manage, Bing-Neel syndrome. And it's unfair to compare high-dose methotrexate and other things that we used to pull out of the closet randomly to treat patients to reflect on, survival curves that were generated in that era of hand-me-down therapies.
Thank you. Can I assume, sorry, Dr. Treon, can I assume that when you talk about Ibrutinib that I can say, well, that could also be Zanubrutinib?
Well, we have less experience with Zanubrutinib. We now know that, at least one patient that Jorge had just presented, benefited. We have a lot more experience with Ibrutinib. But unfortunately, our experience with Zanubrutinib, and both Jorge and I, serve on their global steering committee for Zanubrutinib as well. This is one of the things we want the company to invest, more in terms of our understanding, do the clinical trials with Zanubrutinib to get us a better understanding of the role of Zanubrutinib in Bing-Neel syndrome. There's a good chance Zanu may even turn out to be a better drug because it's given twice a day. And by giving it in that way, they themselves have shown that they can suppress BTK for, at a rate of close to 100% over a 24-hour period. But do we know if that's true in the brain? No, we don't know. So this is why, the kind of studies that we need, include sampling of the cerebral spinal fluid, looking at the cells, looking at BTK occupancy. We're well equipped to do these studies. We just want to, get them done for Waldenström. And right now the company's focused on getting approval of the drug. They just did a beautiful randomized trial, head on. They showed actually more very good responses, what we call very good partial responses, more than 90% reduction in the IgM for people that got Zanu versus Ibrutinib. They also had a slightly better side effect profile with Zanubrutinib. But there's a yin and a yang, less atrial fibrillation, less diarrhea, less bleeding, but more neutropenia when the white blood counts go down. So there's a little give and take there. But at the end of the day, a very good drug, as good as Ibrutinib, if not maybe even better. And that's why we want to get Zanubrutinib on board. Hopefully it'll be approved. It'll be part of our guidelines. And then I think the company will be able to invest in helping to optimize its use, including Bing-Neel syndrome.
Thank you. Thank you very much for that.
Before we say goodbye to Peter, I do want to point out that Peter, along with Julie Davidson, whom I'll introduce in a minute, is a lifeline volunteer for the IWMF Bing-Neel syndrome. So even though Peter is in Australia, now that we know we have Zoom and we can text and chat with one another, Peter and Julie, Julie, can you say something so we can see you? Are you still here?
Yeah, I'm here. I just unmuted, sorry.
Oh, that's okay. So it was through Julie that I found out that there actually was already a support group for Bing-Neel. And so she and Peter are helping to connect people. So before we still have more questions, but A lot of them, we're just not going to be able to get to. I'm so sorry. A number of them have to do with, well, what are the odds that this treatment might work or what that? And I think a lot of that is going to be answered by saying, we'll see, which is my mother's famous answer to just about everything. We'll see, hon. And so we have to just be patient and find out what happens in time. But I have one more poll that I'd like to add before we go, and I would like to offer.
Eileen,
yes.
I would like to say that we do maintain a database, and we have about 35 Bing-Neel patients and caregivers who are connected by email, and we do maintain a list. And if anybody's interested in being on that, they can certainly email me or call me, and we can get you on that list and introduce you to the group. We're not terribly active. We don't have meetings like this, but I'm open to doing something in the future if that's interesting to people.
That's wonderful, Julie, and also to Peter. Their information, by the way, is on the IWMF website under the Lifeline volunteers. So you can get their email and contact information right there.